Welcome to Grand Rounds. We are pleased to have Chris Moriates here from UCSF. To give you a little background on him before he starts his presentation. Chris began his education at UCLA and then traveled to UCSD for his MD and ultimately landed at UCSF for his residency and has continued to stay on at UCSF as an assistant, now clinical professor. He holds many positions at UCSF around his main passion, which is the Choosing Wisely and High Value Care campaigns. He is the director of Caring Wisely in their Center for High Value Care, as well as the director of Implementation Initiatives. He also leads an internal medicine residency's cost awareness curriculum. He, outside of UCSF, has been very involved in multiple journals. Specifically, he's the JAMA series editor for Teachable Moments and is the associate editor for the Agency of Healthcare Research and Quality Patient Safety Network. He's become a national figure in the Choosing Wisely campaign and high value care. He has multiple awards from ACP California as a Young Physician Achievement Award and a finalist in the Society of Hospital Medicine Award for Excellence and Outstanding Service in Hospital Medicine. Much of his research and journal articles are focused on high value care and innovative medicine, innovative high value research. He's been recognized also at UCSF as the Young Innovator and a Caring Wisely Award. We are pleased to welcome him, have him speak on overcoming a culture overrun with overuse.
It's a tongue twister. Thank you. Thank you. It's so cool for me to be here. You know, we've so many friendly faces here in Seattle that have come up from UCSF up to here, and similarly down to UCSF or UW Southern Branch. I sit back to back with Adina Khan. I work with Surisha. I work with Linnea, Reshma Gupta, who you hear about. So lots of folks that we work with together. So first disclosure, I wrote a book that came out this past year, Understanding Value-Based Healthcare. I get royalties from McGraw-Hill, but I got my first check last month. So my real disclaimer is, if you think spending 2 years of your life writing a textbook is a good way to make money, it's not. Don't do that. So there's the late great author, David Foster Wallace, told a speech at a graduation once that has now become kind of famous. The video went viral. And in it, he told a parable. He's talked about two young fish who are swimming along in the water. And along comes an older fish that kind of looks at them, nods, and says, "Morning, boys. How's the water?" And the two fish kind of swim along. And eventually, one turns to the other and says,
"What the hell is water?"
Here's the thing. We are now talking about high-value care. And everywhere people are talking about we need to achieve high-value care, and we're going about it by creating evidence-based guidelines and algorithms and choosing wisely lists. You guys have seen this. I think it is really important that we codify our best practices this way, that we come up with what we should be doing and where the gaps are. But we need to recognize that we're all still swimming in the same water. And that's what we're going to talk about today. This is your culture. And like the surroundings of those two young fish, culture can be extremely difficult to perceive when you're in the middle of it. But it's the undercurrent that drives our behaviors, that contributes to overuse. That is the water that we're all dropped into when we start our training, when we enter this practice. And so I want us today to think about, what is that water? And how do we change it? How do we change the culture around us? Because if we're going to make any progress in actually getting somewhere with these initiatives, that's what we're going to need to do. So, you all know the culture that we live in. 97% of emergency physicians, this came out recently, said that at least some of the advanced imaging studies, CTs, MRIs, that they themselves order are medically unnecessary. The other 3%, I think, didn't admit it, but 97% recognized, and guess what? It's not because they didn't know how to answer the correct answer on the boards. It's not because they didn't know what to teach. It's not about evidence. It's about, this is what we do. You go out into the clinics. This was a little bit older, but primary care physicians, about half of them believe patients in their own practice are getting too much medical care. Basically, none of them thought that their patients were getting too little medical care. And this recently came from someone who just joined our division, Liz Zhang, published this, where she looked at institutions. In fact, UW was one of them, and she thought that she was like, oh, you're going to speak to them. They were amazing at this, I think. But at any rate, she looked at institutions, and she said, the institutional culture and the policies were the biggest predictor. It formed the behaviors of whether trainees, residents, always offered full code, no matter whether or not they thought that it was medically appropriate. So it wasn't about the patient. It wasn't about how sick the patient was or whether the patient would benefit. It wasn't even about who that person, that doctor was. It was about where you dropped them into in their training. What was the culture around them? So this is our culture. This is our water. And I know this isn't very grand rounds like, but what I'd like you to do, because it's early in the morning, I'd like you to turn to each other, and you get 1 minute on the clock, and I just want you to talk to each other about an example that you've seen recently, just thinking about overuse or the culture, or it could be about just what is the culture here at UW. So 1 minute, go ahead. I'm sure that between you pairs you can come up with an example. Twenty more seconds. All right. I know that's not a lot of time. The point is, at first, you may have sat there and thought, huh, and then all of a sudden the stories start coming, I suspect, right? Because the thing is, culture, as the old business adage goes, right? Culture eats strategy for lunch. You could come up with whatever guidelines, whatever strategy you want, but it's culture that is going to drive this. And our success depends on our culture. And I mean that in many different ways. So first, there are studies that have looked at group practices and whether or not they are able to adjust and survive and be successful under healthcare reform. It wasn't about where they were located. It was about the culture within their practice determined whether or not they were able to adapt. And, I think even more concerning, our patients' lives may depend on it. So they looked at acute MIs. And when they looked at acute MIs and 30-day mortality rates, organizational culture was the key factor. Guess what? These places, they had the same policies. They had the same plans in place. What the difference was whether they were rolling their eyes at those policies. Oh yeah, got to get them to the cath lab and check that box for smoking cessation. Or whether they embraced this, this ideal. Patients lived or died. So, hopefully, I'm convincing you that culture is important, that it's all around us, difficult to perceive when we're in the middle of it, but drives our behaviors. And hopefully, if you're paying attention at this point, you may be thinking, all right, fine, but what the hell is culture then? Right? Because the point of the fish parable is that sometimes the most true, most important things are the ones that are most difficult for us to talk about, most difficult for us to wrap our arms around. And part of the problem is that when you Google culture, you come up with lots of different definitions. We have the science one, the organizational science. This culture is the collection of routines and taken-for-granted ways of doing things that dominate all decision-making and behavior. Okay? We have the literary one, which I love, which just says, everything is arranged so that it be this way. And this is what we call culture. Sure. And then, what I think is most easy for us is to just think about the functional definition, which is just culture is the way we do things around here. It's what we do when people aren't looking or asking us to answer something on a test. It's what we do, how we do things. And unless that sounds too fuzzy, like, okay, but what do I do about it? My next thesis that I want to convince you of is that culture can be defined, measured, and tackled. And so if we look to patient safety culture, AHRQ, Brian Sexton around the same time, so groups came up with a survey that would measure culture. What it really measures is behaviors. So it measures behaviors that reflect culture. And those behaviors can be defined, those domains, you can measure them, and you can see that there are differences, not only between UCSF and University of Washington and Virginia Mason, but between, at UCSF, between 9 long and 8 long. Completely different cultures. Importantly, over the last decade or so that they've been studying this, you probably take this, we all take this at UCSF, this survey, and they've seen that it is associated with outcomes. So medical error rates are lower where you have higher patient safety cultures. And so I have the privilege of getting to travel around the country sometimes and go to places and say, oh my God, you should see. At UCSF, we have changed the culture over the last few years. We started this curriculum, and then, we changed all this stuff, and we started this Caring Wisely program, things that I'm going to tell you about today. And I say, it's fantastic. What we've really done is change the culture. And if someone's really paying attention, they say, wait a second, Chris. How do you know that? What do you mean? How do you know you changed the culture? Come on rounds with me. You should just see it's different. How do you know? And how do I change my culture? What was it? What are the things? So, Reshma Gupta, from here, your own, is now a Robert Wood Johnson Scholar down at UCLA. So her with a group of folks at UCLA, a group of folks with myself at UCSF, have created a high-value care culture survey. The idea after that one, where we're defining what are the domains important to creating a high-value care culture. What are the elements that the organization needs to have in place? What are the attitudes that the physicians, the trainees need to adopt? So we've created the survey. We've now rolled it out and studied it, piloted it amongst all of the internal medicine residents and hospitalists at UCSF and UCLA, and we're currently analyzing that and writing it up. So hopefully coming soon. But the point is, we can define what is important in our culture. Okay, what we will spend the rest of the time today about, though, is how do we change it? What do we do about it? So culture's all around us, hard to perceive. Culture forms our behaviors. The world we live in is overrun with overuse. Culture, or at least behaviors that reflect culture, can be measured and defined. Now what do we do? The Institute for Healthcare Improvement has a very simple framework on culture change. They say you have to generate the will, create the ideas, and then execute. Very easy, but think about how often we try to go about this without doing those 3 steps in order. Right? We think, oh, we need to change something. Let's execute. Let's push this down. So what we're going to go through, actually Reshma and myself have worked through trying to figure out what are the different pieces of this that apply to creating a high-value care culture. And the first are champions on the ground. So I don't usually read Deloitte reports, but this report came out very recently where they interviewed CEOs and hospital system leaders, 19 hospital systems across the U.S., the big honcho at each of these places. And they asked them a number of questions. There was lots, I think, of interesting findings in there, particularly related to high-value care and where we're going. But the one I'll point out to you is that all 19 of them that they asked, all of them agreed on this. They said that they have a long-term talent priority of getting physician and clinical leaders who can connect as peers with other physicians in the organization and help drive culture change. So residents, you want to know how to get hired? The rest of you want to know how to get promoted? This is what the leaders are saying they're looking for. They're looking for people that are going to help drive change, culture change. They know that they can't do it, as we'll talk about, themselves. And so we need champions on the ground, and here's why, I think. Because we understand the motivation. So when the CEO or someone else tells us, well, here, we're going to do high-value care, we're going to do choosing wisely, it's really hard for us to believe that they have the same motivation as us. They might. But we all say, like, oh, come on, right? Because when people start talking about that, immediately what starts coming up are these graphs of, like, U.S. healthcare spending and the GDP and numbers in the trillions and things going through the roof. And we ooh and we ah and we gasp in horror. But how many of you went to medical school to treat the GDP? You didn't, right? I didn't either. And so if we make it abstract, if we make it about healthcare costs writ large, we fail to capture the hearts and minds of our physicians. So we don't do that. We need physicians on the ground who are communicating to our colleagues what is it that we're trying to do. And what we're trying to do is improve value. And there's lots of different equations, definitions floating around for what value-based healthcare means. I have started to focus on this one, and the reason I like this one is because the realization that we all want to do the best for our patients. And so, yes, outcomes over cost, quality over cost, very important. But let's just all focus this from the patient's eyes. Because when we focus from the patient, it finally aligns all of our goals. And so when we talk about value-based healthcare, to be clear, what we're talking about is affordability, quality, safety, and experience. The best care at the lowest cost. We are not talking about cheap healthcare. Okay, I don't want cheap healthcare. You probably don't want cheap healthcare. Our patients don't want cheap healthcare. It's like I don't really want cheap oysters, right? What I want is something that's safe, but I don't want to be gouged. Truth be told, I go to Oyster Fest and eat like the cheapest oysters I can find. But point is, you want to know it's safe and that you're getting bang for your buck. And so that's what we mean by value-based healthcare. Safe, high quality, but affordable. But what are we up against? So this is a 1-minute video clip that I pull from a module that we made through the nonprofit I work with called Casa Care. We've created a number of these type of short modules that we've been creating. And in this one, it's representing a resident workroom. Okay? So this guy, Andy, he is the intern on the medical team. Next to him, she is our medical student. And you'll see Paul in a minute, who's the resident. Okay? And in this 1-minute clip, there are 10 reasons that residents overorder tests. I'll give you a hint. It's not fee-for-service. They're not paid. They're barely paid, right? They are certainly not paid more for ordering a CT. So when I go out in the community and I talk about this, and then all of a sudden someone's hand goes up and goes like, it's all about payment reform. Yeah, payment reform is important, but guess what? It's not all about payment reform. It's not about being sued. Residents, you can sue a resident, but it's actually really hard. They're as protected as anybody thinks they reasonably should be, right? They might be scared, they might be worried, but it's not about being sued. So when I go out in the community and they say, it's all about malpractice reform. Yes, that's important. It's not all about malpractice reform. So let's think about the water that we drop our trainees into.
I don't know. What do you think, Paul?
This is bed 1 that we talked about earlier.
Yeah.
Likely pyelo, family history of stones. Well, you could try to manage this conservatively, but if you're even thinking of getting a CT, I'd just go ahead and order. I mean, it takes forever to get a scan around here, plus you'll feel better knowing she won't bounce back, and she'll feel like she's got what she wanted. So it's a win-win.
Yeah, but, I mean, CT is a lot of money. Is that really cost-effective to do that?
Yeah, I've heard CT scans are really expensive. How much do they cost anyway?
I have no idea. Call the billing department. Even if we know how much it costs, it's not like the patient's paying for the CT. I mean, she has insurance, right?
Yeah.
Great. So what's the problem? Look, I know we're supposed to be thinking about costs, but it's not like we're actually equipped to deal with these types of decisions. I mean, no one is going to pat you on the back for pinching pennies. Our responsibility is to the patient.
Look, I found this ACR appropriateness criteria, and it
Well,
looks like
it's up to you, but you may want to check with the attendant first.
That was University of Chicago. Their culture might be different than University of Washington. Here's the thing. We have to change that conversation. We have to change the conversation we're having amongst ourselves. We need to change the conversation we're having with our colleagues, with our consultants, in our medical journals, and with our patients. How do you change that conversation? One is we each do it. You role model. So let me give you an example. My colleague Nader Najafi, hospitalist like me, he told me a story once. He said, I was picking up a holdover patient one morning, so sitting around with his team, the medical students, the intern, the resident there, himself there, and the intern from the night before was presenting the case that they admitted, right, presenting the patient. And at the end of the presentation, Nader turned and said, hey, thanks for not ordering a head CT last night for that patient. She had simple syncope. You probably thought about ordering it, but you didn't. Thank you. Whoa, guess what? When you celebrate restraint, it changes that conversation, which is even a step beyond saying, why'd you order that head CT, which I think is an important first step. But most of the interns tell me that they are all night worried about, well, what if in the morning the attending asks, what did the CT show? And then, God forbid, I didn't get it. They're much more likely to be punished for a sin of omission than commission. And so starting to celebrate that restraint, starting to point out and role model is an important way to change the conversation. Let me tell you about this 55-year-old guy. Healthy guy, just has hyperlipidemia. Goes into clinic and sees his primary care doc and says he's been having about 7 days of a cough and a runny nose, no purulent secretions. They think he's got acute sinusitis. There's no real, risk factors or things to be worried about. So his doc gives him some over-the-counter treatment, supportive care, but then says, if you're not getting better, here's a script for azithromycin, right? Just in case. Of course, 2 days later, he's like, well, I don't really feel better. So he started taking the azithromycin. A couple days after that, 2 days later, he starts noticing, he had never taken azithromycin before, by the way. 2 days after that, he starts noticing that his lips start swelling, his mouth gets uncomfortable, he's having an oral pain sensation. It then evolves into painful mouth sores, irritation of his upper lip, odonophagia, redness of his eyes, and he starts getting mild dysuria by the next morning. He's a pretty smart guy. He stops taking the azithromycin, starts trying to drink a bunch of water and hydrate, but it gets worse. He actually gets a fever. He gets a rash. He gets a ulcer on his penis, and eventually he gets pretty worried. He comes into the emergency room. He looked like this. He had hemorrhagic crusting on his lips. Y'all are smart. What is this? Stevens-Johnson syndrome. He had Stevens-Johnson syndrome. He got admitted for 3 days to the hospital, treated with supportive care, and then went home. He did okay, luckily. But here's the thing. That doc thought, what's the harm? Give him a Z-Pak prescription, and he'll, maybe he'll take it and feel better. What's the harm? Where do we tell these stories? A couple years ago, where would you publish this story? Annals of, oops, look what we did again. I'll tell you, this is not the stories that we tell at M&M. We talk about the crazy, amazing cases. You won't believe what we saw. And guess what? It's important that we tell those stories. It's important. I just had someone, literally, one of my colleagues, one of my mentors, popped in my office and was like, Chris, I got to tell you, we got this CT for this patient. It was this crazy thing. Probably shouldn't have got the CT. Oh my God, it found a FEO. And we looked back, and she has this high blood pressure, all stuff, and we're going to treat her. It's going to make her. Super important that we tell those stories, really. But we got to tell the other 999,000 stories of patients like, oh my God, guess what we found, and then guess what happened. So we tried to create a forum for it. A year and a half ago, we started the Teachable Moments series in JAMA Internal Medicine. Some of you may have seen it. I think it's awesome. I'm a series editor for it, but I think it's really cool for a couple reasons. One is the first author must be a trainee. A medical student, a resident, a fellow, a nursing student, a pharmacy student, a trainee at any level. But the first author must be a trainee. And the second or third author, of course, can be a mentor who will help you. So at any level. The first part is a story from the front lines. A story where underuse, overuse, or misuse led to patient harm. You guys all started coming up with those stories about 10, 15 minutes ago. When I talk to my interns, they can go home that night and write up a story that they saw recently. But importantly, of course, this is an academic journal, so stories are not our point. You tell the story, but you have to match it with a teachable moment, which is what is the evidence? The story I just told you is one that we published. Tell the story of that gentleman, and then you give the teachable moment, which is what does the evidence say about who should get antibiotics for sinusitis? What does the evidence say about how overused are antibiotics in sinusitis? And what are the risks of developing things like Stevens-Johnson syndrome? That's a strategy that I think, if you think about it, people like Atul Gawande use so powerfully. You capture hearts and minds. You tell the story, but you match it with the evidence. And so that's what we've been doing. We've published more than 50 of them. And I think it's helping start to change that conversation. We did this actually on a broader scale in the public through cost of care, which I told you about. Going back years, one of the first things we did was we just said, tell us your stories. Tell us stories, and this was specifically about costs, not overuse, but we said, tell us your stories about how medical costs have affected you or someone you know. We've now collected more than 600 stories from across the country, patients, caregivers, doctors, nurses, and they put a face to the problem so that when we talk about this, it's not about the GDP. And these stories have been picked up and told. They're in the recent Institute of Medicine report. They were the sidebars in order to make this real to us. So I think that there is a very important role to be played by changing the conversation, telling these stories, and matching it with our evidence that we know. But there's another part to building the will. I think it's important that we start to recognize we should leverage societal momentum. Because the other pitfall that I see is that people all of a sudden start jumping to policy solutions. Right? They say, we need to change this on a policy level, on a national level. And the answer is yes, but think about how that's occurred in other societal, other social movements. So, when I was a kid, I remember flying to New York and people would smoke on the airplane, right? That was a policy solution that people can't smoke on the airplane anymore. But guess what? When that happened, before any policy was written or enacted, society had already reached a tipping point. Society already said, we don't want this anymore. So you need to build that will and then leverage it to create change. So where is our society now about this problem? About overuse, about value, about cost? Gallup poll this year, Americans see healthcare as their top financial concern. Top financial concern. What are you worried about, period, about your finances? Number one, healthcare cost, tied with lack of money and low wages. That's a problem. This, published in the New York Times, and it's a little hard to read, I'll tell you what it says, published in the New York Times this past December. And I, like I said, have been following this for years. Since, as a resident, I started our curriculum and was looking into high-value care and costs. I found this really surprising. Because once again, I'd go out and docs would tell me, look, my patients don't want to talk about this. And my question is, are you sure? Did you ask them? Because when the New York Times and CBS News asked them, 80% of Americans that they polled said they think their doctor should discuss the cost of recommended medical treatment with them ahead of time. I'll tell you why that's happening, because more Americans than ever before on high deductible plans, right? And so it's coming out of their pocket. And a lot of those folks are young folks who are used to going on the internet and complaining and uploading their bills and doing stuff like that. What about physicians? Well, this got a ton of press when this came out in 2013. JAMA article, Views of U.S. Physicians About Controlling Healthcare Costs. There's this really shy, quiet guy named Zeke Emanuel, it's a joke if you know who he is, who took physicians to task, right, to anybody who would listen. He wrote this editorial, and he said, when will physicians lead and be the helms? This is an all-hands-on-deck moment. You need to helm the ship, physicians. So frustrated that, quote, only 36% of physicians believe they have major responsibility for healthcare costs. But here's the thing, that same article, same data, showed that 93% believe they have at least some responsibility. We need to concentrate on that. We might not all agree on what level and whether it's all us or the insurance industries. We might not agree on how to attack it, but almost all of us realize that we have some responsibility to this. We need to build that will and leverage it. All right, we're building the will, but then we got to create the ideas. And so there's a couple different mechanisms to do this. I'm going to tell you about a program we started at UCSF that we call Caring Wisely. The idea was choosing wisely is great, tells us what to do and where to look, but doesn't tell us how to do it. And we're about caring for our patients, so we're going to figure out how do we implement, how do we create an organized process for engaging and supporting frontline clinicians in efforts to decrease waste. We created this program, Caring Wisely. And a big part of Caring Wisely is that we get the ideas from the front lines. So every year, we have an ideas contest. Call goes out. The first 2 years, it came out from like our CMO. Now it comes out from our Caring Wisely program, because we now have stature in the community. But it goes out to everybody in the organization. And we say, tell us your idea. It could be a one-liner of how we could cut waste, decrease costs, while at least keeping safety and quality neutral, but in most cases, improving it. And we get ideas from clerks, nurses, from medical students, residents, researchers, literally everyone in the organization. We've got more than 70 ideas each of the last 3 years that we've done this. And then we review them with a bunch of criteria and select the 5 we think best ideas. We then have an open call for proposals. We say, tell us how you would do that. Right? So the ideas are very open, but then we get down to tell us how. And we create the infrastructure, which I'll tell you about in a minute, on how we enact that. So we crowdsource, very important mechanism, I think, getting out and asking the front lines. The reason this is important, I think, at UCSF, the administration literally sits across Parnassus. So you leave the hospital, you walk across the street, you go up in an elevator to the 5th floor, and there's these really nice offices with views of the Golden Gate Bridge. Me and the residents and the rest of us physicians are running around the hospital doing things. They don't really know what our life is and where the waste is. We do. You know who really knows are the interns. The interns know. Ask them, where's the waste? And they're like, oh my God, I sat on the phone for 5 minutes trying to fax a requisition to LabCorp, whatever. Crazy. Right? So we need to ask them, and that's what this does. We need to get out there and ask them. Now, of course, to be clear, we align those ideas with institutional priorities. So we sit around with, the leader, with the CMO and others, and we think, well, here are the institutional priorities, here are the ideas, where do those sort of align? How can we create the best partnership? Crowdsourcing is powerful, I think, not just within our institution, but across the country. So let me tell you about Marty. This is Marty Muntz. He's the clerkship director in Wisconsin. And Marty had an idea. Marty had been, his bosses have been telling him, we need the medical students to be more active. They can't, we need actively engaged medical students. And he'd been hearing, we need to address this high-value care thing. And he thought, how can I do that? How can I bring that together? And Marty had an idea about a high-value care officer program, where he brings his medical students together before they start their internal medicine rotation. And he introduces them to choosing wisely in the concepts and overuse. He put together these very short, like less than 5-minute modules on different choosing wisely concepts. He then empowered them to look for specific examples. So he gave them a checklist of things. And it was like, hey, when your team mentions that they're going to order a transfusion for a patient, look, is the hemoglobin actually, below 7? Are they actively bleeding? He gives them these lists of things. So he doesn't send out rogue medical students to be eaten alive. He also tells everybody on the internal medicine service, the attendings, the residents, the interns, hey, this is something that I am requiring them. So if you've got a problem, talk to Marty. Don't talk to your medical student. It's not their fault. This was a great idea because he actually got the medical students engaged in this. And in fact, preliminary data shows he changed the behavior of the ordering physicians. That's crazy. For an educational program, he changed someone else's behavior. The interns and the residents ordered differently. Fewer labs. The problem is that we are living in a world where we're trying to figure out these things right now on the fly, and this is still not published. I think it will be this year, but this is still not published because it takes a while and because Marty is a busy guy running a clerkship. We need to get those ideas. And so we have a Teaching Value and Choosing Wisely challenge that we run every year. This year we're going to call it the Creating Value Challenge, but that we run every year in conjunction with the ABIM Foundation. And last year was our second time doing it, and we heard Marty's story. And he gave us the preliminary data, he told us what they do, and we thought, that's awesome. And we started highlighting it. Along came 2 first-year faculty members at UCSF who said, Chris, we want to get our medical students more actively engaged. We want to do something about this high-value care thing. And I said, you got to talk to Marty. Marty's got an idea. Don't reinvent it. And so we've created a high-value care officer program now at UCSF, modeled after what they've done in Wisconsin. So we need to collect those best ideas, we need to curate them, and we need to disseminate them. But here's the thing. I see some leaders in the room. Frontline empowerment is not code word for great, you're on your own. Okay, because sometimes I think, oh great, Frontline's empowered, good. Marty, go do something about that. We can turn to my boss, Bob Wachter. You guys know Bob? I'm a hospitalist. He invented the word hospitalist, which if you don't know that, he'll tell you within a few minutes of meeting him. He's like, check this out, New England Journal, 1996. He's awesome. He's my favorite, honestly. But Bob said, look, organizations are generally going to try to create the needed change without addressing, budgeting for, or having the patience for culture change. You say, okay, we live in a new world. We need to do something about it. You're on your own. God bless them if they're successful. But most of y'all won't be. Leaders can't create a culture, but they must create the conditions for a great one to emerge. So people like me can connect Marty and our new faculty, but that doesn't happen in a vacuum. It happens because we have the infrastructure, because we have the leaders that have created that system, that are changing the water. That my chair of medicine tells me, well, now the interim chair is Bob, but before that, Talmadge would say, Dr. King would tell me, this is a path to success. You don't have to write R01 grants. You help change our culture and spread the word, and if you lead high-value care, you're going to continue to be promoted here. That's creating the conditions for this to happen. So back to caring wisely. We are creating a bridge across Parnassus. We're taking those ideas from the frontline staff, and we're bringing them to the hospital leadership, and then we're supporting them. So what that means is each year we select 3 projects that we implement. We implement them over the course of the year. The medical center has seen the value in this, and they now provide up to $50,000 per project. And we tell them we're going to return on their investment. They also, however, this is not a grant program. We don't just throw money at people because it doesn't really help that much. We also have the support. So we have a Caring Wisely team directed by myself. We have Victoria Valencia, who's like our project manager. She's a ninja. She can do anything. She does she pulls the data out of Epic. She creates scorecards. She does all kinds of cool stuff. We've got implementation scientists. And the reason we do that is so that when Karina Zagorakis, our incredible neurosurgical resident, who started an OR scorecard program, graduates next year, her program doesn't go away. And when the anesthesiologists who came in this year and are creating a perisurgical home, they aren't starting from scratch. They're learning all the lessons that I learned dealing with surgeons in the OR for the last year. Right? And so this is a program to create the infrastructure and how you support this type of work. But I want to make this concrete. So I'm going to give you an example. This was from our first year Caring Wisely project. The idea came from a nurse on the orthopedic floor. And she said, I heard we shouldn't be transfusing so much, but we transfuse a heck of a lot here on the orthopedic floor at UCSF. Now, there are 2 strategies. I won't go over the data, but in general, studies have supported that a restrictive threshold is favored over a liberal threshold for transfusions. And so our goal in general was to improve the adherence to a restrictive strategy across our hospital. I'm going to show you how we did it. First, we got Alvin. Alvin is a physician, data scientist, total nerd, awesome guy. He pulled every single transfusion given in our hospital out of Epic. And he had The data was given, which clinical service, who the attending was, and what the hemoglobin was prior to transfusion, and 23 other variables about the patient. It created this giant, giant table that nobody knows what the heck to do with. But here's what Alvin did. He took that data and he translated it into this tree map. This tree map shows you, the size of the box tells you how many transfusions were given in that department. The color tells you what was the pre-transfusion hemoglobin. Dark red, tanked up on blood, didn't actually need a transfusion. Paler, right? All right. Now, zoom in on hospital medicine. This is my world. Each box is a different attending hospitalist. Size of the box tells you how many transfusions they gave. Color tells you pre-transfusion hemoglobin. Have you seen the Dartmouth Atlas before? This is the Dartmouth Atlas for my hospital medicine group. And here's the crazy thing. I sit in a room with these 50 people. I think they're amazing. They're my mentors, colleagues. I thought we were all on the same page. This says we're not. And we saw patterns. So the other key thing about this was you could say execute. All right, we'll just change the order. Or, okay, we'll just have the CMO say our new goal is this. But it turned out that interventions were different for different groups. So hospital medicine, you see lots of variation. Malignant hematology, no variation. Malignant hematology had a protocol. Literally, hematocrit jobs less than 27, get 2 units. That was their protocol. Their intervention has changed the protocol, which they did, by the way. It's still not what I would write for the protocol, but it's better. Question is, how do we make that hospitalist practice more like that one? Right, that one gave more transfusions, but at lower hemoglobin levels. And then another thing occurred to us. That surgeon is an orthopedic spine surgeon. This surgeon is a neurosurgical spine surgeon. They both do the really complex spine surgeries at our hospital. They share patients. They literally cover for each other on the weekends. They did not realize that their boxes, that they look so different. Guess who knew immediately who was who? The nurses and the residents. They're like, oh, that's Dr. A. Dr. A makes me transfuse everyone. Now, I'm not dumb. I did not go to Dr. A and say, hey, you're transfusing your spine patients too much. And he's like, who the hell are you? You're not a spine surgeon. And the response from Dr. A and others oftentimes is like, well, wait a second. You guys know the response, right? My patients are sicker. Did you correct? You need to correct for this and this and this and this. And we said, okay, let's compare to your peer groups in the nation. Who's your peer? He's like, nobody's my peer. So here's the thing. We said, hey, you two, just talk to each other. I can't tell you what to do, but you're clearly practicing differently and you trust each other. Also, I wasn't the messenger for that. The nurse leader on that floor was. The nurse leader brought them together and said, hey guys, we got this data. Talk to each other. Then you got to train. So I went on a tour. I went to anywhere that would listen. I went to grand rounds. I went to noon conferences. And I talked about our Caring Wisely programs, including our blood utilization stewardship. And when I went to hospital medicine, it was really interesting. The residents there, they knew me. I showed them all the studies and the evidence. And they went out, and I know educational programs are not supposed to change behaviors. We saw transfusions go down. We convinced them. They had the power to go change their ordering behavior right then and there. I went one floor below that to the 8th floor. Much nicer room, but noon conference from the neurosurgical residents. Gave them the studies, including ones specific to surgery. At the end of it, they were shaking their heads. Karina raised her hand. She said, Chris, I'm on board. I believe you. I'm not going to do anything about it. I said, why? And she said, because unless you get Dr. A or my attendings to say, it's okay, do this, I can't change a thing. Totally different than the culture one floor above them for hospital medicine. They didn't once say, oh, make my attending say it's okay. Very interesting. So what did we do? We went out, we found Dr. A and the other leading surgeons, and we got them to pose with our poster, Caring Wisely poster. Hardest part of this, getting 4 surgeons to get together. That dude on the left here, he was literally photoshopped in. He's missing his right arm. We were like, we got a photographer to stand in front of the hospital at like 7 in the morning. Anyhow, we hung this on the surgical floors. We're like, look, there are your leaders. They said it's okay. Go forth and do it. We also need to make the right thing to do the easiest thing to do. Okay? So we changed the system. It used to be that if you wrote transfuse, no matter what the patient's hemoglobin was, the default was 2 units. And if you saw that and wanted to change your mind and say like, oh no, only give 1, you had to change it. It wasn't hard to change, but you had to change it. Or if you're like, oh, never mind, patient didn't need a transfusion, you had to click out and then it'd say like, are you sure you want to cancel? And you'd say yes. It was like a ton of clicks. So it took a year of like going to lots of committees, but we changed so that now it says your patient's hemoglobin is blank. And it fills it in, and then it gives advice, and it says either the default is don't transfuse, you click a button, you're done. Or it says transfuse 1 unit, click a button. People thought we'd get pushback, but we didn't because we made it really easy to override. So right below the default button is a little box that says transfuse anyways, because the computer doesn't see the patient bleeding in front of them. Okay? So it was very easy. You can change the default, but no longer is the right thing to do the hardest thing to do. And what this is, if you think about what we did, we addressed this from multiple sides. And so we've created this framework that we call COST. You need to address culture, things like the posters. You need to address oversight, things like the data feedback, systems, things like the Apex order, and training. One more example, morning labs. Here's the thing about morning labs. Like, it's just a ritual that I kind of love. Like, I picked it up during residency, you know? It's like each morning I come in, I like quickly check the vitals of my patient, get a list, and look at their morning labs, and replete potassium like a ninja, right? Like K equals 4.0, like right on. Like I'm playing that game at the gas station, you know, where you try to stop it on an equal number. I was like really good at that. Morning labs became, to me, like swirling the milk into my coffee each morning. Something I do. Did it this morning. It's like a ritual. And I do it very deliberately, but only half consciously. I don't really think about it. It's just a routine. Right? And now, everybody's telling us we need to cut morning labs, including me. And it's sort of uncomfortable. Okay? And Choosing Wisely says, you know, don't check labs in the face of clinical and lab stability. And I say, that's great. How do you know if it's stable unless you checked it? Right? But this is why I love being a hospitalist. Because hospital medicine groups across the country didn't just shrug their shoulders at it. They went to attack it. And so Vanderbilt and Swedish Hospital published recently, and University of Utah and UCSF created programs to attack the morning lab. Oh, that was Choosing Wisely. At UCSF, I think something really interesting happened. Our residents came to us and said, we want to do something about morning labs. We sat around and we thought about culture, oversight, systems, and training. And we thought, how do we capture the hearts and minds? And we said, everybody's focusing on morning lab, and frankly, people don't really care, you know, about like, oh, did you get another CBC or not? But then we thought, we do care about doing right for our patients. Why don't we focus instead on phlebotomy rates? How often do you actually stick the patient when they're in the hospital? Pediatricians think about that. We don't. How often did you have a vampiric phlebotomist hanging over your patient at 5 in the morning with a requisition with your name on it? And so we started a program called Think Twice, Stick Once, led by visible resident leaders. So it wasn't something happening to them. It was something they were doing. Okay, culture change. And we provided feedback twice a month to the teams about how they performed compared to their teams, how we were doing overall. Worked on the system to make the lab more aware that we could do add-ons easier, and training. And when we have those ideas, we have to collect them, curate them, and disseminate them. So we've created a teaching value learning network, signed up 300 people across the country to share those stories amongst ourselves. And I have just a few quick things to leave you with, and then we'll do some questions. I'm spending all day here today, too, so we can talk today. But unless you're sitting here and thinking, well, I can't do this. I don't have a Caring Wisely program, or I'm not the CMO, or I don't lead. I want you to realize that we can all lead from where we stand. And that although I think you need the infrastructure and all these things, it are the small acts that change and transform culture. Think about environmentalism in the green movement. What really matters is policy. What really matters is like, what is Apple doing in China that affects? But we didn't, as a society, sit around and say, okay, well, unless you fix that, I ain't doing anything. Right? We changed our culture. We made it so that if you walk outside this hospital and litter, you're going to get a dirty look. You'll probably get tackled in Seattle, right? That's not how it was not too long ago. If you waste Healthcare resources. If you get an MRI that was totally unnecessary, are you embarrassed? Is it just sort of like, oh yeah, I guess he totally didn't need that? Change the culture. And it was the youth, by the way, and the teachers that changed that culture, that said, this is about conservation. It's about personal responsibility. And yes, advocating for policy and doing these things. Let's all start to do our part. And that's what we're talking about. Let's look at one other example that's actually from medicine. Think about how this applies to high-value care. So, a couple years ago, I was rounding with my team. And I turned to my patient, and I said, do you have any questions? Okay, and I could see the medical students and residents starting to shrink their shoulders, because we had like 10 more patients to see. We were totally running behind. And I turned to my patient, and I said, do you have any questions? And my mind began to immediately chant, please don't, please don't, please don't. And I thought it was quiet enough only I heard between my ears, right? But everybody saw it dancing behind my eyes. They could feel the tension. And my patient was an elderly woman with cancer, admitted with shortness of breath. Her cancer was trying to drown her from the inside, something that she didn't even know was possible until right now. And I could see the fear and the uncertainty and the questions floating around. And she turns to her daughter, and then she locks eyes back on me. And she says, no questions. Thanks. And with that, we all turn, and we're out the door. We're gone with the efficiency of a Broadway scene change. Right? And the thing is, when I first started as an attending a few years back, I had great patient satisfaction scores. In fact, like they highlighted it at one of our faculty meetings, and I was really proud. And now it's only in my second year, and they started to slip just a bit. And I was worried. I was worried this wasn't some meaningless metric, but was indeed the canary saying something is wrong. And I also realized that my own satisfaction with my clinical job was beginning to dip as well. And at UCSF, as across the country, we set our sights on improving the patient experience. So what did that mean? That meant campaigns and acronyms and new C-suite level positions and mandatory online modules, because there are always mandatory online modules, right? And it's important to codify our best practices in this way, but it does not change behavior. I think it's the small acts, the little things. It was Diane Slicka, who now leads patient experience, but didn't at the time, who took it upon herself to teach us simple things that we could do to change the way we talk to our patients. And importantly, Diane led by example. And the first few times it felt like a magic trick. Right? It's a few flipped words. But what questions do you have for me? Rather than, do you have any questions? It completely reframed the way I ended my visits with my patients. No longer, the chant no longer applied. Everyone seemed to notice. She taught us to say, thank you at the end of our visit, rather than just leaving or see you later. It's simple, but it's strangely powerful. And this became institutionalized so that we started actually teaching our trainees. I would run an entire attending teaching rounds every time I'd rotate on communication and language, and think about language entrenched in medicine, stuff like the patient refused their morning labs. No, they didn't refuse. They just didn't understand why they were being woken up with a lab stick for the 6th day in a row, right? And so we thought about that. We thought about how we change our language. This is how you change culture. Right now, each medical student and intern that rotates on picks up, what questions do you have for us, rather than, do you have any questions? It's important. Sometimes I rotate, and I'm with a resident I've never worked with before, and we're on the first day, and she walks in the room, and she says, what questions do you have for us? And I know we are part of the same culture. This has become what we do at UCSF. Now, think about that shift and how that applies to what we want to do with value. Think about where you are 10 minutes from now on rounds. How you talk about that CT or that MRI. How you ask the questions about that lab. Will this change management? These are the type of things that we need to do to change our culture. So with that, thank you very much.